we will be discussing about PCOS phenotypes and the clinical implications. What is PCOS? It is a multifactorial, partly genetic disorder with a number of candidate genes involved. So in short, it is a multi-system endocrinopathy. So what is the global prevalence of PCOS? Global prevalence of PCOS depends on the racial and ethnic backgrounds, and according to different criteria, there is different prevalence of PCOS. As per ESHRE ASRM 2003 criteria, the prevalence is 6 to 21%. There is what is the criteria for PCOS, how it was evaluated? So there were three set of diagnostic criteria that have been proposed over past 3 decades. The first attempt was made by NIH conference in 1990. So what was the criteria which the NIH 1990 put? So they told the two things should be present for the patient to be labeled as PCOS. So what are those two things? One is hyperandrogenism and another is oligoanovulation. So both of things, two things, if present, the patient is labeled as PCOS, provided we have excluded the related or mimicking etiologies. What are those mimicking etiologies? We already discussed in our previous video the differential diagnosis. Again, I will be just summing up. It is the congenital adrenal hyperplasia, the Cushing syndrome, thyroid disorders, hyperprolactinemia, androgen secreting tumors, or any drug induced androgen excess, or the idiopathic causes. So all these things we have to exclude before labeling the patient as PCOS. The second trial was it was a consensus opinion in Rotterdam, Netherlands in 2003, which added PCOM, polycystic ovarian morphology, to NIH 1990 definition, increasing the number of patients diagnosed with PCOS as well as broadened the heterogeneity of PCOS phenotypes as compared to NIH definition. So what was the criteria by ASRM 2003? They told the 2 of the 3 are required to label the patient as PCOS. What are the 2 of the 3 things? One is hyperandrogenism, same as the NIH. Second is the ovulatory dysfunction, and third thing which they added is the PCOM, polycystic ovarian morphology, if it is seen on ultrasound along with either of these two or these two without PCOM. The patient can be labeled as PCOS provided we have excluded all of the related the mimicking etiologies, as I already told. So it was proposed that hyperandrogenism seen to be the strongest determinant of PCOS pathophysiology and is a key predictor for associated metabolic dysfunction. So androgen excess PCOS 2006 criteria excluded the non-hyperandrogenic phenotype that was proposed by 2003 Rotterdam criteria. So what Rotterdam told, even if the hyperandrogenism is not there, if the ovulatory dysfunction is there and polycystic ovarian morphology is there, patient is PCOS. But Androgen Excess Society, what they told, if the patient has both these criteria should be met, then only the patient is PCOS, that is the hyperandrogenism along with the ovarian dysfunction, which means ovulatory dysfunction or polycystic ovarian morphology. Okay, so ovulatory dysfunction, ovarian dysfunction must be there, which can be PCOM or ovulatory dysfunction, but hyperandrogenism is a must. So if hyperandrogenism is not there, patient is not polycystic ovarian syndrome. So these were the different criteria. These were the different how there was evolution of the different definitions of the PCOS. So now we will be it is just a comparison of different NIH 1990, ESHRE 2003, androgen excess PCOS in 2006. Then came the NIH 2012. So the NIH in 2012 undertook an evidence-based methodology, PCOS workshop. So there was a workshop in which what they did, which they led to the formation of different phenotypes of the PCOS. I will be discussing what those phenotypes are. What they told, 2 of the 3 required criteria which the Rotterdam told, plus identification of specific phenotype. Okay, so this is what the phenotype A, B, C, D, according to that we have to label the patient, which will have further clinical implications. So what are those phenotypes? So these are the NIH 2012 extension of ASRM, ESHRE ASRM 2003. So phenotype A means hyperandrogenism is there, ovulatory dysfunction is there and polycystic ovarian morphology is there on the ultrasound, then you will label the patient as PCOS phenotype A. What is phenotype B is when there is normal ovaries. The ovaries are normal, but patient has hyperandrogenism as well as ovulatory dysfunction. What is phenotype C? When the cycles are normal. There is no ovulatory dysfunction, only patient is presenting with hyperandrogenism, that is clinical or biochemical, or there is polycystic ovarian morphology. Both are there, but the cycles are regular. What is phenotype D? D is when there is the morphology of the patient is correct, not the ovaries. Means the patient is normal, there is no hyperandrogenic features, but she is suffering from some ovulatory dysfunction, and on ultrasound the polycystic ovarian morphology is there. How I remember this thing is, in A everything is there, in B, because the ultrasound we are doing on the B mode, we are doing ultrasound on the B mode, so the polycystic ovarian morphology, the ultrasound is normal, so we are doing it on the B mode and ultrasound is normal. Other two things are there. How the C, cycles are normal, so cycles are normal, so that is not there. Other two things are there. So B mode means the B mode is normal, C means cycles are normal. So this is how B and C can be easily remembered, and A has everything. What is excluded is D. So D means there is no hyperandrogenic features. Okay. So this was the proposed phenotypic approach is highly convenient for clinical practice. Yes, it is actually convenient for clinical practice. Why? Because these are the patients which require these are the most difficult patients to manage, the patients with phenotype A. So the practical applications of NIH 2012 phenotypic classification is to identify PCOS women at highest risk of metabolic dysfunctions, because these are the patients which land into most of the ovarian the clomiphene resistance. We have to do LOD in these patients, and these are the patients who land into OHSS, and the longer stimulation protocols we have to follow for these patients. And these are the patients which later on suffer from diabetes, hypertension, and all the cardiovascular risk, obesity. So these are the patients which have the most highest risk of metabolic dysfunction. So the differentiating the patients into different phenotypic ways, the NIH has made easy for the clinicians to identify the women who are at the highest risk. So thank you. I hope this is clear, the different PCOS phenotypes and how the criteria for PCOS, the definition was evolved. Thank you.